please.
Thank you very much. Thank you, Mr. Chairman. Thanks for the kind introduction. I'd like to thank the organizing committee for the privilege of joining again your meeting here in Israel and enjoying your hospitality. Thank you. So the title is Heart Team in Action in Europe. The concept of the heart team was actually exercised in the syntax trial, and it is an effort to place the patient presenting with coronary artery disease, complex coronary artery disease and comorbidities at the center, and to bring at the bedside all specialists who can help that patient, particularly with respect to revascularization, be it interventional cardiologists, cardiac surgeons, or clinically oriented cardiologists. The task force of the EACTS Guidelines on myocardial revascularization actually was a sort of heart team because we had a nice mix of these three disciplines. Now, what are the tasks for your local heart team? There's many things you can do. I think it's important to evaluate the results of PCI and CABG in your own environment for benchmarking. It's very helpful to organize morbidity mortality conferences. One key element of the recommendation was related to patient information and consent. Information first, consent second. It by no means is the concept of heart team antagonizing the fact that the patient is being treated by his own physician and therefore anonymous treatment should be avoided. And of course, the idea of the heart team is to create care tracks or clinical pathways that address the different clinical presentations and that the heart team agrees upon, so we don't have to meet to discuss every patient. We have no time to do that. And therefore, this allows to draft institutional protocols that are as much as possible compatible with the best of our EACTS guidelines. Now, when you implement a heart team approach in practice, there is a lot of potential impact. And this is a study that looked at the adherence to ACC/AHA guidelines for indications of PCI and CABG. It's a very large group of patients admitted to the cath lab, and the authors tried to identify for each patient which would have been the to-be recommended treatment based on the guidelines. And they compared these recommendations or theoretical recommendation with what actually happened. And what you see here is that in this large group of patients, they thought that CABG would have been the guideline recommended treatment, and in fact, it was only offered to about half of the patients. This was not the case for PCI. When the guidelines would recommend PCI, in more than 94% of the cases, this is what actually happened. And we can go on like this, but the bottom line of this study is that 92% of PCI procedures were done ad hoc, and that the chances of getting PCI were actually increased in laboratories where there was PCI facilities. On top of that, we have to recognize that the patient, when asked, will obviously prefer the less invasive PCI over surgery. So the choice of the patient or the patient preference will be strongly influenced by what the physician is recommending to that patient, knowing that our goal should be to be less invasive in all cases. And in fact, patients seem to have misconceptions regarding the benefits of elective PCI, not the benefit of PCI in acute conditions, but elective PCI. This is not a study from the US in which they asked to the patient having undergone PCI, what do you think is going to be the benefit of that procedure? These are elective cases. 1/3 of the patients were not sure whether the treatment had been done as an emergency. Only 1/3 felt that this therapy would help their angina, where in fact this is very efficacious in doing so. Many patients felt that the PCI procedure would have an impact on their life expectancy, and very many, actually the majority, felt that it would prevent further heart attacks. Of course, disturbing, particularly to the surgical colleagues, the fact that only 13% of the patients, the surgical option was discussed. So it's not misinformation, but certainly misunderstanding on behalf of the patients as to the benefits of the various procedures, and that's why in the guidelines we recommend that the information to the patient should be much better improved from what it is today. Now, on purpose, I started on a controversial mode because indeed in some areas, not in all, but in some areas, the heart team recommendation, class 1C, has been heavily debated and somewhat controversial, and certainly it has been the case initially in Israel. Some have questioned the composition of the heart team. The issue of patient information and process for decision-making as recommended in the guidelines has also been questioned. Many have resisted our recommendation to use risk factors as a means to shape the decision. One very hot issue has been the fact that ad hoc PCI is felt by many interventionalists to be the best option. And of course, all of this questions the practice of self-referral that many of us interventionalists like to practice in daily life. Altogether, this heart team recommendation has the potential to impact on the relative indications for PCI and CABG, particularly for the indications that are the border zone, like triple vessel disease or left main disease. And some have even argued that our practice guidelines were skewed towards surgical options because of its composition. And as a matter of fact, in the US, scientific societies have not produced joint guidelines like we have done in Europe. So why has the heart team recommendation been debated or controversial? In many occasions, I guess there is territorial thinking. So let's come back to the patient, because that was the fundamental idea behind the heart team. Now, when you talk about it on theory, positions tend to polarize. When we go down to practice and examine the individual case, in the vast majority of instances, situations is much easier. So I'd like to discuss with you a case. And if you agree, Mr. Chairman, I'd like to involve you, because we have a fantastic heart team here on the podium. So listen carefully. This is a 70-year-old gentleman that presented to us a little less than a year ago. He has the classical risk factors, hypertension and hypercholesterolemia being treated. He also has significant comorbidity, particularly lung disease. He has had paroxysmal AFib in the past, but is now in sinus rhythm. There is no history of acute MI. He presents primarily with dyspnea and some chest pain that was felt to be atypical. Blood pressure was not well controlled on admission. He had some indication for heart failure. I'll show you the thorax picture in a second. He has had probably some lung emboli in the past, but this was not active. This is his chest X-ray. Okay. ECG. Okay, still a lot of QRS. He's in sinus rhythm, diffuse repolarization abnormalities. Very likely inferior infarct. Also poor R progression, precordial rights. This was the medical therapy that we gave him on admission. He improved, no beta blockers because of the lung disease. The lab tests, nothing remarkable really. Preserved renal function, just mildly elevated glucose levels. Okay, the patient went to the cath lab. We were surprised by the high pulmonary pressures. There is certainly pulmonary hypertension. Most of it was secondary to left heart dysfunction. Cardiac output was preserved at rest. This is a poor left ventricular angiogram. Quality is poor and also the function is poor. You can see that there is some filling defect perhaps here at the apex. And there is some degree of mitral regurg as well. Now the left coronary artery. This is a 6 French injection. I'll show it to you again in a second. So this is a REO view, short left main. The mid-circ seems to be occluded or suboccluded with at least 2 posterolateral branches here. The LAD in this view seems diffusely diseased, but in fact its mid part is suboccluded. This LAO view confirms the subocclusion of the circumflex with some prograde filling, and as a matter of fact the LAD here is occluded over a rather long segment. Once again, after this big diagonal branch here, this is the LAD that should go down to the apex. On the right side, diffuse disease and very slow filling distally, better seen here. On this AP cranial view, there is actually diffuse disease in the mid portion, but the distal right is also occluded, if not, looks chronic occlusion. Okay, so to summarize, we have triple vessel disease with the 3 vessels suboccluded or occluded, the circ in its mid part, the LAD in its mid segment, and the right distally with a significant posterolateral branch, as shown here on this schematic. The LV-gram shows severe dysfunction with apical akinesia and some thrombus at the apex. Ejection fraction is measured below 30%, and right heart cath in this patient with chronic obstructive lung disease shows pulmonary hypertension. So I'd like to ask our heart team on the podium, if you don't mind, what would be your recommendation? And allow me to start with Chaim. Dr. Lotan, can you treat this patient with PCI and stents?
Well, the question is, can I treat or should I treat?
Let's start with can I treat?
I think it's feasible. It's not a 100% guarantee, but I think it's feasible to definitely to open the LAD and probably also the right. So from a practical, technical point of view, it's feasible.
Yeah, Chaim is obviously alluding to the important progresses that have been made in the percutaneous treatment of chronically occluded vessels where, you know, if you want, in the vast majority of cases with expertise, you can end up opening the vessel. So, yes, you can. That's your answer. Would you do this ad hoc?
Well, I have to consult first with the entire team.
So, Dr. Sahar, you're part of the team. What can you offer to this patient?
Well, of course, a surgeon can offer only surgery, but I think that practically this patient is a surgical candidate, even though the ejection fraction is low, but it seems to be that he has good myocardial reserve. The coronary vessels are suitable for bypasses. And it's a little bit annoying that this patient has a thrombus in his left ventricle. But even though he sustained the ventriculography, so I don't really expect a serious neurological problem during surgery. I think that this patient would get, in most centers, at least 3 bypasses. He would have a lima to the LAD, which seems to be a quite viable portion of the heart. You would get maybe a radial graft to the circumflex artery, and then maybe a saphenous vein to the right coronary artery. I think that this patient can benefit from surgery.
Thank you. So,
well,
yes, Chaim, can I come back to you?
Now, after listening, I beg to differ. And the question is really the viability. As you mentioned, there is a quite signs of necrosis. You have Q waves in the inferior wall. You have poor wave progression in the anterior wall. I think that we don't know the viability of both walls. For me, which will be more important, is the mitral valve. I think that if we have a significant mitral disease and we didn't have enough knowledge about the mitral, it might push me a little bit more towards surgery. If the mitral valve has only small mitral incompetence, I would have gone with percutaneous therapy.
This is to answer your question, Chaim. So this is the perfusion exercise on top, rest right below it. And with perfusion, there seems to be a very severe fixed defect, inferior wall and apex. We completed this perfusion study with FDG imaging. And if you concentrate, for instance, on the inferior wall here, that seems to be gone completely with perfusion. Actually, in terms of metabolic activity here, under the right metabolic conditions, there clearly is life in the inferior wall. So that addresses your question. You said, Chaim, I can do it, but you said, maybe I shouldn't. Why do you have reservation? You said mitral valve. Is there any corner reason why you have reservation to treat it with PCI?
Well, the point is that, as you have shown now, you have a scar in the infraapical area. So whether you're going to be successful or not, you're probably not going to change significantly the prognosis. I think, and we had a wonderful session in the morning about mitral valve and the importance of mitral regurgitation long term. I think that if this patient, due to the infarct, has significant mitral regurgitation, that might have much more effect on his prognosis than opening the totally right coronary.
Okay, and Dr. Sahar, are you concerned about comorbidity for surgery?
Yes, for sure. I would just like to answer a little bit the question of Professor Lotan. I don't think that the mitral is really a serious problem here, because we saw the LV angiography. And here we can see that this patient has a quite good viability, and we know that if you have viability of at least 25-30% of the myocard, those patients can benefit significantly from revascularization. So I think both of us agreed that this patient needs revascularization. The question is what kind of revascularization we can offer him, and I still insist on surgery.
Thank you very much for this great discussion, and actually you're helping me to make the point. Of course, there is the case of this patient, but beyond that, there is the wealth and the beauty of having this discussion. I mean, proposing the best possible treatment to complex patient is not an easy task, and it's not just a matter of technical feasibility, and I think your discussion illustrated that beautifully. What we have done at our place, with our experience, our surgeons, is refer the patient to surgery. He had the lima to the LAD in the diagonal, a jump, and they have decided to place a vein graft, a jump graft on the two marginals and the RDP from the right. They also have a very low threshold for placing rings on leaking mitral valves, even in this post-ischemic situation. The post-op care that we were a bit worried about, given the comorbidity, actually went fine. Just to remind you that we took into account these two scores, the your score, probably overestimated risk of death or MI at 1 month, 17%, pretty high. Fortunately, didn't happen. The syntax score, that reflects the complexity of the coronary anatomy and its amenability to PCI, particularly with respect to the number of stents that would have to be placed, was very high, above 34. So the decision was easy, based on the recommendations of the guideline. Actually, what we did is exactly what the guidelines recommended, because this patient has a high syntax score. So irrespective of other factors, these are his two curves, the two curves from the syntax trial. Patients randomized to surgery enjoyed a very significant reduction in the composite endpoint. Now, if you talk to the patient and the only thing you tell to the patient is, I can do the PCI, he will go for PCI. But if you talk to the patient and explain that the risk of death is what it is with either treatment, that the risk of CVA in this particular case is actually not higher with surgery in that study, that the risk of MI is 4 times higher with PCI than with CABG, and look at the risk of revasc as well. So in this particular case, it's not difficult to talk to the patient, explaining that all the components of the composite endpoint that he's caring about go in the same direction in favor of surgery, if you have a good surgical team that can treat those patients efficaciously. So we are in this situation here. Triple vessel complex lesions, incomplete revasc, likely with PCI. As Chaim said, he was going to focus on the right and the LAD, with a very high syntax score in that particular case, class 1A recommendation for CABG, and 3A, meaning that it's not recommended to do PCI in this particular case. If you add the mitral valve to it, debatable whether it's significant or not, that would even give more weight to the indication for CABG. Situation is not so easy in a number of other cases, particularly left main, either left main with isolated shaft or ostium lesion, or even more complex left main with double or triple vessel disease, but a low to intermediate syntax score. Under those conditions, of course, surgery can be considered, no problem. It's a 1A. But we also have 2A indication or even 2B for PCI. So some surgeons have misinterpreted this slide and said 1A is higher than 2A, therefore it's always surgery. That's not the case, because as a matter of fact, 2A means should be considered, and 2B means may be considered. Now, if you want to consider, you need to discuss, and that's why the heart team. I said it was more difficult in those situations because here, from the combined endpoint, we seem to have equipoise. These are patients with left main disease from the syntax score. The two curves run superimposed at 3 years, confirmed at 4 years. And it looks like going one way or the other doesn't make any difference. Well, it's much more difficult to talk to that patient, because if you look at the components of the composite, they're not in the same direction. Yes, with surgery, you're more likely to have CVA and mortality. With PCI, you're more likely to have MI, more likely to have revasc. So how do you talk to those patients? How do you inform them about the choices? That is more difficult. And as a matter of fact, as we've seen, many patients don't have a good understanding of what those procedures do. This is a study on patient information showing that they underestimate the need for reintervention with either procedure. And in fact, when you explain to the patient 0.5% risk of something, bad event, only half of them actually understand what that means in terms of them having or not having an MI or a stroke. So that's why in the EACTS Myocardial Revascularization Guidelines, we made a strong point to take the time to inform the patients properly. And probably the best way to do so is to make sure they're informed already prior to the diagnostic angiography. It is clear that ad hoc PCI is a very good way to treat patients, many patients, provided they are well informed prior to diagnostic angiography. And actually, there is a document in the guideline that you can download or translate, and probably you have your own, to really explain to the patients what the disease is and what the various treatments achieve. And in fact, when you're dealing with very complex patients, multivessel disease, the recommendation is that they should be discussed by the heart team, and this recommendation has also been taken over now by the recently published US guidelines. So I'm finishing. What has been the impact of those guidelines, and particularly with respect to the heart team? First of all, these guidelines have been endorsed by nearly all, I think actually all ESC constituent bodies and national societies, and also by a number of surgical societies. As I mentioned, the heart team concept has been heavily discussed in some countries, not at all in others. For instance, in Northern Europe, Scandinavia, heart team was a given. It is applied in many other diseases, such as the treatment of cancer. No one would argue that the multidisciplinary approach to the treatment of cancer is needed, so why would complex patients with coronary disease not benefit from it? I have to admit that the recommendation is a 1C. It's based on the advice and the opinion of the experts. There are no reports yet of potential impact on patient outcome, but we have many reports that the guidelines have changed the practice, and in particular, that the patients with very high syntax scores, lots of coronary lesions, ending up with lots of stents in case of PCI, are now preferably referred for bypass surgery. And the heart team concept is also being used in the design of the EXCEL trial, randomizing patients with left main disease to surgery versus PCI. And I have to say that the heart team concept is now endorsed also for the treatment of valvular heart disease, particularly the use of TAVI. And of course, this is a matter that will evolve as new evidence comes by, and there will be an update, or at least a new joint EACTS guidelines released by the ESC in 2014. I thank you for your help with the case and for your attention. These are my disclosures.